Welcome to Neoadjuvant and Adjuvant Chemotherapy for Bladder Cancer, a patient insight webinar from the Bladder Cancer Advocacy Network. We'd like to thank EMD Serrano and Pfizer, Ferring, Insight, Genentech, and Merck for their support of the Patient Insight webinar series. I am joined today by Dr. Matthew Galsky of the Mount Sinai Hospital in New York.
I'm going to start out very basic, and that's certainly not to minimize anyone's pre-existing knowledge of this subject area, but I just want to make sure that everyone's on the same page. The other comment is that I'm going to try and stay away from very specific data in terms of going deep into the woods and really focus more on general concepts, but I will be showing some data as well because I think it is necessary to reinforce some of the concepts and make sure that everyone understands what a clinician is thinking about when they're making some of these treatment recommendations. So to set the stage, of course, the bladder is an organ that sits towards the bottom of the pelvis, and it's connected by these long tubes called the ureters to the kidneys. And the kidneys filter the blood, maintain balance of fluid and electrolytes in the body, filter toxins, and that creates the urine, of course, which drains down the ureters and gets stored in the bladder. And the bladder's just that, it's a storage device for urine. You can see the wall of the bladder here, and the bladder is a relatively thick-walled organ, and you can see that this is blown up in this cartoon here. And what I want to point out here is that like every organ in the body, the bladder is made up of microscopic cells, and you can see these cells here with the nucleus in purple. Cells are the building blocks of all of our organs, and normal cells in our body have a fixed lifespan. They do their job, and then they die, and new cells come to take their place. For reasons that we don't understand, sometimes an abnormal signal occurs in an individual cell. This can really occur just in one cell, a mutation in the DNA related to some exposure, related to the environment, related to inherited genes perhaps. In that mutation tells the cell that instead of dying that natural process, it should continue to live. That cell can divide, like all our cells can divide, but its offspring inherits that abnormal signal. So that cell continues to grow and divide as well. So if you have all these cells that are growing and dividing without dying, then they start to accumulate and they form masses or tumors. And that's what cancer is. Starts out as one cell in the body that gets this abnormal signal that tells the cell to start to grow uncontrollably and accumulate. So you can see normal cells lining the bladder here, and there's also in this cartoon some representations of bladder tumors, collections of cells that started to grow in this abnormal pattern. When cancer of the bladder occurs, it typically starts on the inside wall of the bladder, and that's why when the urologist, when they put their scope up into the bladder, they can see the tumor because they're looking at the inside wall. That's also why not uncommonly a presenting sign of bladder cancer is blood in the urine, because this tumor irritates the lining of the bladder and then red blood cells pass in the urine. When bladder cancer grows, despite it starting on the inside wall of the bladder, typically the growth is deeper into the wall of the bladder. And this area right here labeled muscle is a very important landmark in the management of bladder cancer. And when that layer is involved with cancer, we call that muscle invasive bladder cancer. And it's an important landmark because we know that the risk of bladder cancer growing and progressing and spreading is higher once that layer is involved. And therefore, typically, once that layer is involved, a standard part of treatment is removal of the bladder or cystectomy. There are some other forms of definitive treatment like radiation as well, but surgery is one of the backbones of treatment for muscle-invasive bladder cancer. Surgery for bladder cancer, for muscle-invasive bladder cancer, can be a curative approach, and it's a curative approach in many patients. But we know that the deeper the cancer invades into the wall of the bladder, the less likelihood that it will be a curative approach. And we know that because if we monitor patients years, months to years after treatment for bladder cancer, after having their bladders removed, a subset of patients will develop recurrence of the cancer. The cancer will show up somewhere else in the body. And that's reflected on this figure here, which is called the Kaplan-Meier curve. And just to orient you here, in the x-axis is the years after surgery, so the years after cystectomy. And in the y-axis shows the probability that the cancer hasn't come back. So everyone at time 0 starts out at 100% because no one's cancer has come back at time 0. But as time passes, you can see that there's an increasing likelihood of the cancer coming back up to about 4 to 5 years, and then this levels off. And we know that the risk of the cancer coming back or recurring after that time is much lower, and that's why we usually talk about 5-year survival as this important landmark time point, as the likelihood of cure after that time is substantial. Shown here, in addition to the likelihood of cancer recurring after surgery, is the finding that the deeper the cancer invades into the bladder, the higher the likelihood that the cancer might come back. And that's going to be important a little bit later when we talk about adjuvant chemotherapy. So when a cancer of the bladder is diagnosed, the first thing, of course, that's done is that the cancer is staged. And staging is just our term for understanding where the cancer is and where it isn't. And one of the most important components of staging is the depth of invasion into the wall of the bladder and determining if the cancer has invaded into the muscle layer or not. But another component to staging is determining if there's cancer elsewhere in the body. And we typically do that with things like CAT scans or MRIs. And so you might be wondering, and it's really the very appropriate question, you might be wondering, if I have a CAT scan or an MRI before surgery and there's no evidence of cancer, and then the cancer is removed surgically, the bladder is removed surgically, how can the cancer come back? How can there be a recurrence? And this term recurrence is really a misnomer because it's not that cancer magically recurs. But even before surgery, unfortunately, in some cases, there will be microscopic spread of the cancer. And our current technology in terms of CAT scans and MRIs, as much as that's improved over the years, is still quite limited in our ability to detect small amounts of cancer. So what I've shown here is various degrees of volumes of cancer cells and what that would equate to a size on a CAT scan. And you can see here that 1 centimeter, which is about the limit of detection on CAT scans or MRIs, we're getting a little bit better at seeing things less than a centimeter, but often very difficult to know what something might represent when it's less than a centimeter in size. A 1 centimeter mass on a scan represents a collection of about 1 billion cancer cells. So when a CAT scan doesn't show evidence of spread or an MRI doesn't show evidence of spread, ultimately what we're saying is that there's probably not collections of cancer cells that range in the billions, but we can't definitively rule out smaller amounts of cancer that might have spread. And we have a very difficult time differentiating no spread of cancer at all from spread of 1,000 cells or spread of 1 million cells. And this is really the crux of the issue here in terms of understanding whether or not surgery alone will be curative or not. And if we could detect these small amounts of cancer cells in a reliable and reproducible way, then that would certainly enhance our ability to individualize treatment. And there are attempts to study novel methods to improve upon our abilities here. But right now, we really rely on conventional CAT scans and MRIs to make this decision. So if there are a subset of patients who have microscopic spread of cancer, then we know that removing the bladder alone will likely not address those collections of cancer cells because they've already spread outside of the bladder. And so about 3 decades ago, a concept was developed not just in bladder cancer, but in various types of cancers that was based on the hypothesis that if we could use surgery to adequately control or remove the primary tumor, then perhaps we could use systemic treatments, like treatments administered intravenously that would flow wherever blood might flow in the body, chemotherapy, to kill microscopic cancer cells which might have spread. And that's an important point, that might have spread, because that's relevant in terms of how some of these treatments have been developed and how we interpret some of the data. When we give that treatment, when we give systemic treatment like chemotherapy prior to removal of the bladder, it's called neoadjuvant chemotherapy. When we give it after, it's called adjuvant chemotherapy. There are some pragmatic and some scientific reasons why giving chemotherapy first prior to surgery versus after surgery might be more beneficial. From a practical standpoint, because surgery to remove the bladder is not an insignificant surgery, oftentimes it's easier for patients to tolerate chemotherapy when it's given prior to surgery compared to after cystectomy. Another consideration with giving chemotherapy prior to surgery is that while I said that we're talking about cancer that might or might not have spread, and so in an individual patient, it's difficult to impossible to know if the chemotherapy has provided a benefit, and I'll expand on that point a little bit more later. When chemotherapy is given before surgery, we can determine the response to treatment within the bladder itself when it's removed, and that can often serve as a prognostic indication as to how microscopic cancer might have responded to chemotherapy, if indeed it was present. When we give chemotherapy after surgery, as I mentioned, it's called adjuvant chemotherapy. And a major consideration with giving chemotherapy after surgery is the fact that after the bladder is removed and it's analyzed by the pathologist in the laboratory, we really get a much better, a much more precise indication of how extensive the cancer is locally in the bladder and whether or not the lymph nodes are microscopically involved. And so our ability to prognosticate, our ability to guess whether or not cancer has spread microscopically is enhanced by that information.